Hi everyone, in this video I'm going to talk about what tests you should be asking your doctor for and what cholesterol numbers really matter. You're going to learn the difference between a lipoprotein and cholesterol and what an imaging test can really give you an idea of what your risk for heart disease truly is. It's a great webinar, and at the end, as usual, there's a great Q&A, so stay tuned to the end. With that, let's roll. Hey everyone, welcome to another webinar. This is Dr. Bhavesh. I focus on wellness-based medicine, and we're here to talk about cholesterol again. And today I just want to go over the standard lipid profile that you're going to get with any regular doctor's visit and blood work, and which you've probably had before multiple times. In my practice, often people are concerned about their cholesterol levels. They decide if they're healthy or not based on their cholesterol levels. I wanted to sort of break down what those cholesterol numbers are telling you, but I wanted to remind everyone that the cholesterol numbers have not been predictive of a heart attack or a stroke. There are people who have low cholesterol who never have a heart attack and stroke. High cholesterol will never have a heart attack or stroke, and people who have low cholesterol who do. In fact, about 50% of people who have a heart attack or stroke have normal cholesterol, so it just hasn't been predictive of a heart attack or a stroke. The other thing is the body does need cholesterol for its essential functions. It's important for memory, prevention of dementia. It's important for infection-related mortality or death, cancer-related deaths. The nervous system depends on how each cell individually functions, dependent on having the right amount of cholesterol. So because we haven't been predictive of the heart attacks or the strokes or the bad outcomes with just cholesterol alone, and we're taking so many medications for it, these sort of webinars are just to bring the thinking back up to what's current versus sort of the outdated thinking. And unfortunately, it's just present amongst the general population and amongst physicians in general as well. So a standard lipid profile is going to be checking you for your cholesterol levels, but it's not checking you for the carriers of cholesterol. We covered this in another webinar, but I just want to briefly consider the difference between lipoproteins and cholesterol, so it helps us understand the lipid profile a little bit better. Now, again, cholesterol is a molecule that is the building block of other hormones and other molecules. So you need cholesterol in general for the body to work. In fact, it's so important that your body actually makes it. It makes 75% of the cholesterol. Only about 25% comes from diet. Most of that's not even absorbable. The body still has to sort of manufacture its own hormones from the cholesterol, or manufacture its own cholesterol. But that cholesterol has to get transported from one place to another. And the way it does that is it's carried on lipoproteins. So let's just say you have a cholesterol molecule. I'll just make them triangles today. And you have to get them from one point to another. If you've got, let's say, these 6 cholesterol molecules, you could maybe take that in one big truck that's going to get you from point A to point B. And this component here is called a particle, all right? And that might be an LDL particle, or it could be an HDL particle. Okay. Now, let's say the particles are a different size and you have smaller ones. And now you need some smaller vehicles to get it from point A to point B. Now, these are also particles. But here the difference is you had one particle here and two particles here. Let's just break it down even further. Let's say the particles that carry cholesterol get smaller, meaning the vehicles get smaller. And now you've got maybe like some kind of rickshaw or something like that. And you've got 6 of them. No one's going to accuse me of becoming an artist, that's for sure. All right, now you've got 6 of these particles going across. Now remember, the amount of cholesterol is the same. It's still the 6 molecules of cholesterol, but you're either taking it in particles of 1 particle, 2 particles, 6 particles. Now we do know the more particles there are, that it's going to lead to more plaque formation, right? And plaques in the artery is what we're trying to avoid in terms of trying to prevent for a heart attack or a stroke or arterial disease in general. All right, so knowing that there's a difference between particles and cholesterol, let's talk about the standard lipid profile that we're going to have. So in your testing, you're going to have what's called the total cholesterol. Now, this is a number that we used to think greater than 300 was bad. Then they said greater than 250 was bad. And now they say that greater than 200 is bad or abnormal. I'm just going to put a quotes around that because, again, we know that there's people with higher levels of cholesterol who never have heart disease and people with lower levels who do have heart disease. But again, it's just a good initial check to see what your total cholesterol number is. The next number people always talk about is the LDL number, which is quote unquote the bad cholesterol. And that number can be either greater than 130 is bad if you have some risk factors. If you have some heart disease, greater than 100 is abnormal. Some people want to see it less than 70. So all of these can quote unquote be abnormal based on how rigid they want the LDL management to be. But I want to point out that not all LDLs are bad. There's actually some large, fluffy ones that are type A and they're good. They're sort of like those larger vehicles we talked about earlier. There's also a type B, which are the bad ones. Now, I think about Bs and I think about BBs, like little BBs that can get stuck in the blood vessel walls. These are the smaller ones, the smaller, denser ones. So in this example that we use today, those 6 rickshaws or whatever that are carrying those 6 molecules, those are the small, dense particles that can get stuck in the blood vessel walls. Now, it's important to note that when we're looking at the number here, it's a measure of cholesterol. We don't know how many particles there are. We don't know exactly if there's 1, 2, or 6 of the vehicles that are carrying the cholesterol, just to use that example that we were using earlier. So if that's the case, why do we have this? Well, this is the total amount of cholesterol carried by the particles. And honestly, it's just an estimation. It's estimated from the triglycerides. Now, this is why the triglycerides on a standard lipid profile are probably why it's my favorite number in the lipid profile, because it's going to give us the best insight into particle counts. Generally speaking, the triglycerides go higher, you're going to see more particles. Particles. Can I spell today? All right. So increased triglycerides equals increased particles. And the reason I like it is because this is carbohydrates, portion sizes, and alcohol that raises that up. And so those are all lifestyle factors that we can control. We can decrease our carbs, we can decrease our alcohol, we can eat smaller portions. Taking omega-3 fatty acids like fish oil are helpful here. So we can increase that, decrease this. So it's modifiable lifestyle factors that we can do that'll probably change the particle count. Now, the cholesterol may stay the same, but if we're carrying all that cholesterol in a fewer number of particles, that's what we're trying to achieve. The next one is HDLs. This is quote unquote the good cholesterol. And generally that's true. The higher the HDLs are, the lower cardiovascular risk we see or disease. Okay, I like to see this greater than 50. This can get into the 80s and 90s. There may be a concept that's not really testable, but uh, too many HDLs they may be non-functional. There's not really a test for it. But greater than 50, 80s and 90s, the reason the HDLs are good is just purely association. I don't know if we understand the mechanism completely, but we just know that the higher the HDLs are, we just don't see the cardiovascular disease as easily. What improves that? High intensity interval training, so HIIT training that you may have heard of, helps improve the HDLs. Good fiber helps improve the HDL. I like fiber from vegetables preferably versus grains because of the carbohydrate in the grains is going to cause the insulin spike, and that can cause some weight gain and other metabolic issues. So if we can get it mostly from fiber from vegetables and high intensity interval training, that's going to raise the HDL. Uh, the other number that you're going to see on a typical profile is VLDL. That moves with the triglycerides. So I just ignore it because I'm looking at the triglycerides. When the triglycerides go up, so does the VLDL. When the triglycerides go down, the VLDL goes down. But in the past, for a little while, doctors are looking at the VLDLs as a possible risk marker. Again, I think the triglycerides are a better measure for that. Finally, the risk ratio. This is one that people see and they assume it directly means risk. And unfortunately, we already know the whole cholesterol profile in general isn't predictive of a heart attack or a stroke. So it's hard for us to say that there's a ratio or a risk ratio that's predictive. Having said that, understanding what it is still helpful. It's going to be your total cholesterol versus your HDL fraction. So all of your cholesterol versus the quote unquote good cholesterol. And the lower that number is, the better, right? That means you have more HDL in comparison to total cholesterol. Where this is useful is, let's just say you see a 250 total cholesterol, you say, and you're told that that's bad and you have to get on a statin. Well, if your risk ratio is lower, let's say 3.5, the reference range here goes up to about 5.4 before it's abnormal. If it's about 3.5, meaning that the HDLs are high enough to counteract the non-HDLs, it may not be as big of an issue. Conversely, if you have, let's say you have what's considered a normal cholesterol, it's like 175, but your risk ratio is like 6.8. Well, we know that's mostly the LDLs, which are going to be the ones that cause the plaque formation. We may not know the particle count, but we do know that the ratios are not good. So this is something where you're going to want to change your diet and improve your lifestyle to get that risk ratio better. So that's kind of how I use those numbers. So for me, I'll be looking at triglycerides first. Then I'll probably peek at the HDLs. Then I'll probably look at the risk ratio. Finally, I'll look at the LDLs and then the total. But I guess first, number one for me is going to be triglycerides because I think that's the one where we have modifiable impact. Risk ratio, just to be a quick idea of good versus bad. And then the rest of it is absolute numbers. Now, there's a lot more that goes into heart disease and heart disease risk, like family history, inflammation, genetics. Those are things to be thinking about as well. Testing you can do around this is particle testing. You can see what the particle counts actually are. There's imaging you can consider. Imaging is looking at the blood vessels themselves. So there's MRIs that can be done. There's angiograms. So the reason I say that is if the lipid profiles are not predictive and then the particles give us a better insight, but they're still not completely giving us the full picture, why not just look at the blood vessels themselves and MRIs and angiograms by CAT scan? are available. Functional imaging, like a stress echo, see how your heart moves, or if there's any issues with low blood flow to the heart under exercise, is important to look at. And purely from a risk factor perspective, what's going to cause a heart attack is not just the plaque, but it's the inflammation around the plaque. So something like an HSCRP, which stands for C-reactive protein, is a test that's worth considering. And then again, for some people with family histories, there's some genetic markers. Maybe we'll do a video on this at some point, but there's like the ApoE gene seems to be predictive. There's something called 9p21, KIF6. So these are genes that might give you an insight into whether you're more at risk or less at risk. And all of this is to say, if we have more data, we could decide how aggressive we want to be with therapy. Therapy being a lifestyle modification. Some people, statins may be appropriate. I think they're probably overused. There's some new medications like PCSK9 inhibitors, which reduce just the LDL component, which are the plaque formers. Then there's cholesterol uptake, reuptake inhibitors. Certainly a number of medications, but the question is, what's your real risk, and how much do you want to do to get that number down? Again, so we kind of started with just the lipid profile, how I analyze what's in your standard lipid profile, what you're missing, and what you can't see with the lipid profile, and what additional tests you might consider. Hopefully this webinar so far has been useful for you. We have time for a couple of questions. So Angela, could you check the chat for me and see if we have anything?
Dr. Patel, we do have a question. Someone wanted to know, why does HIIT affect the HDL levels differently than regular cardio? How does it affect?
Yeah, it probably has to do with the hormonal systems that the HIIT engages. So when you're doing standard aerobic exercise, you're in your fat burning zone, and that's good for burning fat, but it doesn't engage the anaerobic system and the growth hormone production. So the HIIT training, because of its intensity, it's short burst, high intensity exercise. It engages the body to produce growth hormone, which produces some muscle mass. And so we know lifting weights tends to increase the HDLs. The HIIT training probably works in a similar way. That's probably about the depth of my knowledge on the actual mechanism scientifically, but I know that the HIIT training engages the hormonal systems differently than the aerobic, and there's probably a mechanism there for which it causes that HDL elevation. But it's been well documented, let's put it that way, so we know it works.
We have another question concerning the LDL and the HDL. Is there ways to lower that LDL other than just diet and exercise and medication?
Well, yeah, really, it's going to be I think it's going to be, it does get down to the diet, exercise, and if you need it, medication. It really does just come down to that. I can't think of anything else. There might be some, there's a supplement that people use called berberine, which seems to help lower the cholesterol. And then what's the other one? Red yeast rice. So people use red yeast rice to lower it. So if you're looking at supplements, those are two that seem to lower the HDL. Red yeast rice actually works the way statins do. It's what's called an HMG coenzyme A reductase inhibitor. It stops the production of cholesterol. I think if you're at the point where you're looking at red yeast rice to reduce cholesterol levels, I would just think about a low dose statin. Again, I prefer not to have to use statins, but if I'm looking at red yeast rice, which we don't know exactly the impact it's going to have based on the sourcing of it, versus a medication where I do know the source of it and how much is in there and how effective it's going to be, I'd probably just choose the medication because the mechanisms are the same. Let's see if we have time for one more question, Angela.
We do have one last question. Someone wanted to know if your doctor seems intent on putting you on these statins and you do not want to be on the statin, is there a certain type of doctor that you can look for that can provide you alternatives to the medications?
Yeah, good question. So first of all, if they're insistent on putting you on a statin, the first thing is it's your body, and you get to choose what you're going to take or not. And the reason for this series of webinars and the reason for the way I love practicing medicine, it's because I want to educate the patient so they understand what these numbers are, what they mean, why they're important, and what your choices are. So the choice is ultimately up to you to decide if you want to take the statin. And if you know the risks and you know what the benefits are, and you decide how much risk you want to take, because look, there's a risk for taking a medication, and there's risk for not taking the medication. Uh, but right now, medicine has gotten to the point where they're seeing so many patients per hour. There's just sort of standard guidelines in place. They're designed for the population. Sometimes the data isn't always the best, and they're not individualized to what's right for you. And so, you should be able to have a conversation with your physician that you don't want to take a statin, and these are the reasons why. Especially because in somebody who doesn't have heart disease or hasn't had a cardiovascular incident in the past, taking a statin hasn't shown to be preventative of that. So, unfortunately, there just are physicians who believe that because you're over 50 or because your cholesterol is 202 instead of 198, that you should be on a statin. And I think if they're kind of doing that kind of knee jerk medicine, I think you need to take charge. And those are the times when you see if you can educate that your provider. If not, I would look for functional medicine practitioners. Functional medicine practitioners, the philosophy is to figure out the problem at the source and correct the problem at the source versus see the problem and then give a pill to bring the number down or mask the problem. So, for example, like if you have uh, high cholesterol, there's a reason you have high cholesterol. And as long as you don't change anything, that number is always going to be high. Sure, I can take a pill to make it go down, but if I don't correct what's going on, you still have the process of high cholesterol production. That's the same for diabetes. It's the same for any process in the body. It's fixing it fundamentally is what's key, and that's where a functional medicine practitioner is going to be helpful. That's again, go to Google and go to their website and find a practitioner, or type in functional medicine practitioners near me. They're not always MD. Sometimes there's DOs and nurse practitioners, and they're all really good. Okay, with that said, I hope everyone learned something useful today. Hopefully, this analysis of lipid profiles, you can see there's more to glean from it. It's not as simple as total cholesterol. And I hope this helps you decide if you're going to do any additional testing, and will help you decide what course of therapy is the best for you. Have a great day, and thank you very much for tuning in. Bye-bye.